everyone. Well, it says my Facebook is not connected, so let me work on that for you.
Oh, I was
Look
muted
amongst
for a
yourselves.
minute. Yeah, I was just looked down and saw I was muted. Enjoying seeing where everybody's from. I was sitting here watching it scroll to different places. Some of you guys I know well. Looks like a couple newcomers. Thank you guys for popping in. I did see a note say something about Facebook. Yeah, an error occurred.
Yeah, bummer.
It didn't go through Facebook, but that's okay. We still have plenty of people here that actually register, and therefore you come in through StreamYard, the platform that we use, and we're on YouTube, Facebook, and X. I see a lot of you guys are coming in from the same state, so I'd be curious if you guys know each other. Maybe you're coming in from the same chapter. I know that you could be from the same state and not know each other. However, it would be a lot of fun if you guys did make that connection.
I'm going to put your comments up on the screen. If you want to say hello, where you're from. And I'm just running a little behind. I'm trying to get my slides up. I think, Alicia, you have your slide deck, so I don't have to worry about mine.
Yeah, I got them both up. So if I need to, but then again, you need to drive for yours.
All right. Thanks to Mary for keeping us organized with all of our links.
Kimberly, you're in Lincoln, Nebraska. I did some contract work up in Lincoln, Nebraska. Drove all the way through Nebraska practically. Margaret's from Maryland. I'm going to slide up through here. Julie from Phoenix. And of course, Denise, Missouri City, Texas. And me living in Missouri, that I like seeing that.
All right, share screen.
I know some of you guys were sharing your weather too. It's lovely here. We've got beautiful weather, and some of you guys are getting snow, or not snow, rain and dreary.
Not here in Florida.
No, it was kind of steamy here, and in our new house, I've got a big wraparound porch, so it's screened, so it's kind of lovely. Just put a fern out on the front porch today. My mother-in-law bought one. You guys, we have an exciting day presentation for you guys today. We have one topic, percutaneous coronary interventions, which is abbreviated PCI. We're going to talk about the CPT coding on that. And then we also have a lecture that would be excellent if any of you are interested in cardiac coding. We've titled it Speaking Cardiac, Basics every medical coder should know. And these are two topics that you'll hear a little bit of overlapping in. Maybe the verbiage will be familiar to you if you have already done your cardiac module, if you're taking a course, or if you've done any work in cardiology. Feel free to.
This is a very meaty webinar tonight.
Yeah, we're not going to get done. It's going to be over. This will run a little long compared to some of the others we've done, and it's excellent content, excellent slide decks for you guys tonight. Really excited to let you see them.
So we want to give a shout out to Kristen Estes. She's been really killing these slide decks, doing great. And also behind the scenes, we have William from our help desk who helps us as well with just keeping us organized, and Mary, our project manager, and Sylvia helping as our subject matter expert. So we've got a nice team behind the scenes. So we appreciate all of our club members that help support us, and you're the ones that help us bring this content to everybody, and we appreciate that. But the club members are the ones that get the goodies. So in case you're saying, oh, those slides are gorgeous, and they are, I want a copy, or I want any extra handouts that we show, or I want to ask a follow-up question because this was a lot of information and, I need more on this particular subtopic. You go to the club, you see this in our replay, and it's attached to CEUs. You can ask questions there and have a nice conversation with us. So that's the club, cco.us/club, because we normally get people asking, can I get CEUs? Can I get the handouts? Yes, you can as a club member. So, and because AAPC keeps charging their prices, raising them for the CEUs, it was $330 for one stinking CEU. Now it's $412. So we need more members just to pay for one CEU a month. And we want to get CEUs. At any rate, can you tell I'm a little miffed? At any rate, let's let Alicia kick us off with her topic, and then I'll do mine when she's done. So go ahead and share your screen, and I'll remove
I am going to move some of mine around here because I want to make sure I've got.
We have a special we want to share with you, so I'll do that in between our topics, our little commercial break.
Hold on just a second. I hit the wrong button. When you have so many screens, it gets kind of hard.
I'll give them a preview while you're pulling it up.
Yeah.
So the next slide, we're having a big spring sale. We were going to start it in a couple of days, but we decided to start it tonight so we can announce it on the webinar.
Got it.
You got it. Hang on, let me just finish this slide here. Oh.
No. Let me unshare because I took some notes.
Sorry, guys.
My notes aren't showing.
It's not like this is our first time or anything.
They'll let anybody do this.
So while we're doing the webinar, if you want to check it out, cco.us/spring-sale, 25% off all of our courses, even the new CDI course. And you can get the annual club membership for just $199 instead of $249. That's a huge savings because you already get a savings just by doing the annual. You save 2 months. Now you save even more, which effectively makes your monthly rate less than $17. So that is a good deal. At any rate, you can look at that, and I'm going to turn the show back over to Alicia.
No, because now I'm ready. The topic that I'm going to talk about today is speaking cardiac, basic everyday medical coder knowledge, and it is going to be really full of information. So feel free to have your notebook ready and take down little notes if you have questions. We're going to actually break down cardiovascular terminology. That's really important. And we're going to also give you the coding in a way that's going to hopefully make sense. We're not going to give you jargon overload, I promise. Now, whether you've been actually coding for a while or you're just getting comfortable with cardiology cases, this session is going to give you the confidence to tackle cardiac coding like a pro. So let's just jump in real quick here. The first thing we're going to talk about is why cardiology coding is such a big deal. And honestly, it is. Cardiology is one of the highest volume specialties in healthcare. I mean, think about it. Heart conditions affect millions of people, and these patients are seen all the time. That means we're coding cardiac cases constantly, and accuracy is absolutely critical. And, here's why it matters so much. First, it directly impacts reimbursement. That's important, of course. If we don't code accurately, the facility doesn't get paid and what they should. Second, there's compliance. You know how important it is to stay on the right side of audits and regulations. And cardiac coding errors can really make a huge impact and come back to bite you if you aren't careful. Third, and this is the one I think that gets overlooked sometimes, is patient care continuity. When you code accurately, we're documenting the patient's journey correctly, which helps every provider that's following the care of the patient. So yeah, cardiology coding, it really actually matters quite a bit. Now, before we can code anything, it's really important to make sure that we can speak the language. And that starts with understanding the basic anatomy of the heart. You don't need to have the entire heart memorized, all of that anatomy that you see in those really intense pictures of the heart, but you do need to know the key structures. So we're going to start with the chambers. The heart has 4 chambers. We have the right atrium, the right ventricle, we have the left atrium, and the left ventricle. Know that atrium is on top, ventricles are on the bottom. I always think of atriums as attics and ventricles as the basement. Blood flows through these chambers in a very specific way, and knowing which side is which really helps you when you're coding conditions like heart failure and valve issues. Now, we've looked at the valves. There's 4 of them. Don't forget that. And you've got a pulmonary valve, tricuspid valve, aortic valve, and mitral valve. What happens is these valves actually control blood through between the chambers and out of the body and lungs. When you see the documentation about valve stenosis or regurgitation, you need to know exactly which valve they're talking about, because that's going to drive the code selection. Excuse me while I get a drink. Hmm. Mm. And if you look at the diagram here, great diagram, you can see all the major vessels that we'll be dealing with. We have the superior and inferior vena cava, the aorta, and the pulmonary arteries and veins. Now, I know it looks like a lot, but trust me, the more you code cardiac cases, the more familiar you become with this knowledge. And just keep this image in your mind for a reference point. Think of the heart here with the chambers, the 4 chambers, the 4 valves, and the major vessels. Now let's look at some terminology that you're going to see over and over again in cardiac documentation. The first one that you're going to see most of the time is ischemia. And what does ischemia actually mean? Actually a simple term, and it means a lack of adequate oxygenation or blood flow, so you don't get enough oxygen to the tissues or the organs. In cardiology, we're usually talking about reduced blood flow to the heart muscle itself, and that's typically because of narrowed coronary arteries. If you live long enough, you end up with coronary artery problems. So now let's take a look at the visual here. On the left, you've got a healthy artery with normal blood flow. On the right, you've got a narrowed artery, and the reduced flow is called ischemia. The heart's not getting the oxygen that it needs. Now, let me give you a coding tip though, because you'll often see this documented as myocardial ischemia or cardiac ischemia. And again, you'll see it not only in the documentation, but you'll see it in the imaging and tests that are done. They'll pick this up. And that's really important, because ischemia is not a heart attack, at least not yet, but it's definitely progressing to one. Therefore, when you're coding, pay attention to whether documentation actually says ischemia or infarction, because those are 2 very different conditions and they're coded different. So now that we understand ischemia, let's talk about what an infarction is. So the ischemia is the reduced blood flow, but when ischemia goes on for too long, then you can develop an infarction, which is actually tissue death or necrosis caused by prolonged ischemia. Now, when you deal with cardiology, you say myocardial infarction, And we're talking about a heart attack when you hear that term. The heart muscle has actually been deprived of oxygen for so long that part of it actually dies. That's what necrosis means. That is a very serious condition. It's life-threatening. From a coding perspective, though, this is where things get specific. You need to pay close attention to the documentation. In ICD-10, it differentiates between acute versus old infarctions. An acute MI is a new event, and an old MI is one that's healed if it's in the patient's history. Those codes are completely different. They're still I codes, but they're different areas. You also need to know whether it's a STEMI or a non-STEMI. Now, we've given a lot of education on this. In fact, just a couple presentations back, we talked about this exclusively. A STEMI stands for an ST elevation myocardial infarction, and non-STEMI, or it's NSTEMI, is a non-ST elevation. And that comes from the EKG findings, and it tells you actually the type of severity of a heart attack. The codes are very specific to the location and type, so always check the documentation carefully. Don't just grab a generic MI code. Drill down and be specific. We're going to also look at arrhythmias. Now, arrhythmias are just an abnormal heart rhythm. The heart can be too fast, it can be too slow, or it can just go in and out. It can be just plain irregular. And there's different types of arrhythmias. So let me give you some examples. If the heart's beating too fast, that's called tachycardia. If it's too slow, that's bradycardia or bradycardia. And if it's beating irregularly, all over the place, one of the most common examples is arterial fibrillation, or AFib for short. You'll always see the AFib. Now, you'll see AFib all the time in documentation. It's a relatively common condition. I want to give you some coding tips about that, though. When you see that a person has an arrhythmia, you also need to look for how long it's been going on. Is it paroxysmal, meaning that it comes and goes? That's usually how it starts. If it is persistent, that means it lasts longer but can still be treated. Then you also have chronic, and that means it's ongoing, probably permanent. And it's important to show that distinction in the coding because it affects it affects the continuity of the care of the patient. You don't want to overlook it, but pay attention to the documentation so that you have the proper descriptors in there. We're going to move on to stenosis. If you've lived long enough, you get stenosis. That is common. And it just means there's a narrowing or a constriction of the blood vessels or heart valve that gets in the way of blood flow. It's pretty simple. In cardiology, stenosis is really common. Again, you live long enough, you're going to get it. You'll see it in coronary arteries, or if you do, that is called coronary artery stenosis. You'll see it in the heart valves as well. The most common one is aortic stenosis, and then we have mitral stenosis, where the valve gets narrowed and blood just can't flow through as easily as it used to. Now, if you look at the visuals, on the left, you've got a normal artery and normal valve. It's nice and open, doing what it's supposed to do. But on the other side, you've got coronary stenosis and the aortic stenosis. See how much narrower those openings are? And that ends up being a problem. Here's what you need to know for coding. Identify which vessel or valve is affected. You also look for severity. Is it mild, moderate, or severe? If it isn't documented, then, and you're seeing a cardiologist, the testing's been done, you probably want to query. The documentation should tell you if you're at a cardiologist. Reading the reviews or doing an independent interpretation, you're going to have this identified. And if you look at the table, you can see the different types of stenosis, where they occur, and what you need to code. Specificity is going to be the key with stenosis. Don't just code stenosis, code which artery or valve, and note the severity if it's documented. We're going to move on to procedures, and the first one we're going to look at is a CABG. You may have seen that abbreviation before. It stands for coronary artery bypass graft, but most people will call it heart bypass surgery. We will say CABG. Actually, it's a surgical procedure, and what they do is they literally bypass the blocked coronary arteries by using a graft. They take a blood vessel from somewhere else in the body, usually a vein from a leg or an artery from the chest or the arm. They usually take the mammary artery, depending on where it's at on the heart, and use it to reroute blood around the blockage. It's really actually amazing. Now, here's what you need to know for the coding, though. The CPT and the ICD codes depend on the type of graft used and the number of grafts. When you look at the codes, you need to look at the documentation and see, did they use a saphenous vein from the leg, a radial artery from the arm, or an internal mammary artery from the chest? And how many grafts did they place? There could be 1, 2, 3, they could be 4. All of these affect the codes you choose. So document this precisely and make sure you're reading the operative report carefully. Pay attention to the documentation. We're going to get into the actual coding part. So let's start with something simple like EKGs or ECG codes. They're in the range of 93000. These codes really cover standard electrocardiograms, which is basically just tracing the heart's electrical activity. It's a very common procedure that's done. You've probably even seen millions of EKG documentation notes. Well, here's the thing. There are different codes depending on what your practice actually did. And I'm going to break them down for you here. Code 93000, if a complete service, that means the practice did the recording and the physician did the interpretation and the report. It's the whole package. Code 93005, if you're just doing a tracing, the technical component with no interpretation. You're going to code 93010 for the physician interpretation and report with no tracing. Here's the key for the coders. Make sure that documentation clearly shows whether your practice performed the technical portion or the professional portion or both. You need to bill the right piece. A lot of times the tracing is done by the hospital or a facility and the physician just reads it, so you don't bill 93. No, so you'd actually bill the 93010 if that's all that's being done. But if you have a practice that does everything, you're going to bill the 93000. Just read the documentation and make sure that you're billing accordingly. We're going to also talk about stress tests, cardiac stress tests. These are codes 93015 through 93018, and they're for exercise or pharmacological stress tests. Now, that means the patient is either exercising like on a treadmill, or they're given a medication that mimics exercise and the heart's response is monitored. Just like with an EKG stress test chart, the tests start often split between the hospital or the facility who does the technical part and the physician does the supervision and interpretation. You are going to bill the correct piece depending on the documentation. We're going to walk through the codes now. Hold on. It's really dry here. The first code is going to be 93015. If it's the complete test, now that's going to be the supervision, the tracing, the interpretation, all of it together, package deal. 93016 is just the physician supervision, no tracing or interpretation. 93017 is just the tracing, the technical component, and 93018 is just the physician's interpretation and report. The key point here is the same as with the EKGs. Know what your practice did and bill accordingly. If the hospital did the tracing and your physician just read it, you're billing 93018. If your practice did everything, it's 93015. So read the documentation and you'll get it right. We'll move on to some more complex procedures like cardiac catheterization. They get a little tricky. These codes are in the 93451 to 93533 range, and they describe diagnostic catheterization of the heart and major vessels. There are a few variables that are going to affect the code you choose, though. First was the left heart cath, right heart cath, or both done. Second was coronary angiograph performed at the same time, and it a lot of times is. And third, were there any additional hemodynamic measurements taken? And they often are. All of that factors into the code selection. So let's look at some examples we've got here. Code 93451, that's going to be right heart cath only. 93452 is the left heart cath only. 93453 is for a combined right and left. And then you've got codes 93454 through 93461, which are for coronary angiograph combinations. And then we go on. We have pediatric or congenital heart cath procedures. They're going to be 93530 to 93533 range. What you have to remember is to always read the code description very carefully. When you work with these procedures, they get very complex, and there is even add-on codes for things like ventricular colpography, that's a hard for me to say, or graft imaging. You'll see a lot of times. Don't just grab the first code you see. Make sure you're reading the full documentation and matching it to the correct code or codes. Moving on to pacemakers and ICDs, that's implantable cardioverter or defibrillators. The codes for these are going to be 33206 to 33249 in that range. And they cover insertion, replacement, or revision of permanent pacemakers or ICD systems. Now, these procedures can get complex, so we're going to break them down. You might be coding for the insertion of a new permanent pacemaker, and that could be a single chamber or a dual chamber. So you got to pay attention. You might be coding for the insertion or replacement of an ICD system. Again, single, dual, or multiple leads. Or you might be coding for the replacement of the pacemaker pulse generator, which is basically just popping in a new battery. And then there are codes for removal if the device is being taken out. What do you need to know specifically? Type, is it a pacemaker or an ICD? Number two, number of leads, single, dual, or multiple. And if this is an initial implant, replacement, or an upgrade, because they don't last forever, all of that is going to drive your code selection. Now, it's going to be important to read the operative note again very carefully to make sure you're pulling out all the details. Don't assume, always verify it in the documentation. We're going to switch gears and we're going to actually talk about diagnosis codes. Yay! We're going to focus on the I20 through I25 range. Now, when you see those I's, think ischemia, starts with an I. These are going to cover the ischemic heart diseases. And this is a huge category. You'll see these codes all the time. Now, if we break these down, we've got I20.0 through I20.9. They're going to cover angina or angina pectoris, and that's that chest pain from reduced blood flow that we talked about before. It includes stable angina, unstable angina, and variant angina. I21 codes are for acute myocardial infarction or AMI. That's actually your heart attack that someone could have. And within that, you've got STEMIs and non-STEMIs, STEMIs, which we talked about earlier. I22 and I23 are for subsequent MIs. Now, that's a second heart attack, but it's within 28 days of the first and complications following an MI. It's very common. That's why these codes are there. I24 covers other acute ischemic heart disease. I25 is for chronic ischemic heart disease, things like an old MI, atherosclerosis, and post-CABG status. For some coding tips, you need to choose the code based on the acuity. Is it acute or is it chronic? And you need to look at the location. Is it an ST elevation or a non-ST, which would give you the STEMIs and non-STEMIs. And you need to check if there's a history of a CABG or a stent in the past. And your ICD-10 has really specific combination codes like I25.110, which is atherosclerotic heart disease with unstable angina pectoris. Those I25 codes, there's couple pages of those in your manual. Always look for combination codes first before coding things out separately, and that'll keep you accurate and compliant with the codes. If we move on, we're going to look at I48, which covers all the fibrillation and flutter codes. You're going to see AFib a lot, so it's important to understand how to code it correctly. With ICD-10, it differentiates the type of arrhythmia. I48.0 is for paroxysmal AFib. That's when it comes and goes. I48.1 codes for persistent AFib, and you need to differentiate between long-standing, persistent, and other types. I48.2 is for chronic AFib. That's permanent ongoing AFib. I48.3 and I48.4 are typical and atypical atrial flutter. And I48.91 is unspecified AFib. But you really want to avoid using this one unspecified if you can help it. It may be an initial diagnosis until other testing and diagnostic results come in. Coding tip, always code the most specific type documented. If the documentation says, for example, paroxysmal, use the I48.01, or excuse me, 0.0. If it says persistent, you're going to use the I48.1. If it says chronic or permanent, then you're going to use the I48.2. Don't default to unspecified unless there's truly no other information. If you're seeing a cardiologist, you probably have specificity there. And if the documentation mentions both flutter and fibrillation, you code them separately unless there's a combination code available. Always get the specificity. Specificity is your friend. As we go on, we're going to look at heart failure codes next, which are going to be the I50 category. Heart failure is also super common, and there's a lot of different types. So you need to be able to read the documentation carefully for your code selection. The first code we're going to look at is I50.2, and that code is for systolic heart failure. That's when the heart just can't pump effectively. I50.3 is for diastolic heart failure, and that's when the heart can't fill properly. I50.4 codes are for combined systolic and diastolic, so both are being a problem at the same time. I50.8 code is other types of heart failure, and I50.9 is unspecified, but again, avoid unspecified if you can. This is overcoded so often. The coding tip I'm going to give you is you need to identify the acuity. Is it acute, chronic, or acute on chronic? That's huge. That's the first step in picking the right code. You also need to identify the type. Is it systolic, diastolic, or combined, which would be systolic on diastolic? And if the documentation is specifying left versus right heart failure, make sure you capture that. All of these details affect which specific code you use. And again, as always, read the documentation. Don't just grab a generic heart failure code like I50.9. It is when I see that, it's a real big red flag on an audit. There are some common mistakes that coders make with cardiac coding, by the way. I think it'll be helpful for you to know these pitfalls ahead of time so that you can avoid them. The first one is upcoding or downcoding. So don't report a higher or lower code than what was actually documented. If the document supports a specific level of service or procedure, that's what you code, no more or less. Second, don't miss the add-on codes. Cardiac procedures often have add-on codes for things like ventriculography, that one I can't say, the angiography or supplemental imaging. Make sure you're reading the full operative note and capturing the work that was done. Now, the third tip I would give you is misinterpreting global periods. Some procedures have post-op care bundled in, and you can't bill separately for follow-up visits during that global period. Make sure you understand what's included and what's not. Going in and putting stents a lot of times have a 0 global period. Fourth, unspecified codes. Be careful. ICD-10 is all about specificity. If the documentation is going to support a specific code like I25.110 for atherosclerotic heart disease with unstable angina, then use that code. Don't default to I25.9, which is just unspecified ischemic heart disease. Always go for the most specific code you can. Those unspecified codes are red flags in cardiology for audits. And fifth, missing the technical versus the professional split. We talked about that with the EKGs and the stress tests and catheterizations. You need to code the correct component based on what your practice actually did. Don't assume you verify it in the documentation. Now, let's kind of wrap it up by what you need to see in the documentation to code accurately. There are some key documentation requirements that should be in the medical record. The first being medical necessity. The diagnosis needs to support the procedure that was performed. And if the documentation doesn't show why the procedure was necessary, you're going to have trouble with reimbursement and audits. Second is laterality. Right versus left matters with the heart, especially when you're coding for specific vessels or valves. Make sure the documentation specifies which side. Third, device type. Is it a pacemaker or an ICD? What's the specific model, if it's relevant, and that information needs to be in the op report or the op note. Fourth, how many leads did the pacer have? Are you talking about a single, dual, or multiple chamber system? That affects the code. Fifth, graft type and number. For a cabbage procedure, you need to know whether they used a vein or an artery and how many grafts were placed. That's critical for accurate coding. And sixth is acuity level. Is the diagnosis acute or chronic? And that distinction drives your code selection in a lot of cases. So you're reading the documentation, make sure you have all the elements. And that's why people get confused with cardiology coding. There's a lot of things that you have to make sure are in place to get to the highest specificity. If something's missing, you query the provider. Don't guess, get the information you need to code accurately. Before we wrap up, though, I want to share some essential resources that every coder should have in their toolkit. First, you're going to have a CPT manual from the AMA. They have a monopoly on that, so it will say AMA on there. That's where you're going to find the latest procedure codes, and it includes the full code description and guidelines. Make sure you're using the current year's edition. Every year cardiology gets a little tweak and a little love. Second, your ICD-10 CM official guidelines. Now, there's multiple manuals that you can get there. Sometimes you have one that's a favorite. These are the rules for diagnosis coding, and you need to know them inside and out. You'll have all kinds of BAT technique and highlights done in ICD as well as CPT. Then know that they're updated every year, actually twice a year, so stay current with that. Third, you're going to need the CMS NCCI edits. This is going to help you with global periods. That's the National Correct Coding Initiative edits, and they tell you which codes that you can build together and which ones you can't. It's super important for avoiding those bundling issues and denials to have access to the NCCI edits. You're also going to need specialty coding guides from organizations all over. You can get them from the AMA, you can get them from the AAPC, you can get them from AHEMA as well as ACTUS. There's a lot of places that you can get specialty guidelines. Those guides are going to help you specifically focus on cardiology, and they're going to give you a lot of helpful context, but they also give you examples. And finally, clinical consultations. Partner with the clinicians in your practice. If the documentation is unclear, don't be afraid to ask questions, especially when you need specificity because you have so many options. The physicians and the providers are the best resource for understanding what actually is happening during a procedure. So keep those resources handy and use them. They'll make your job a lot easier, and you'll be able to code with confidence with those. Now, we've covered a lot, so let's talk about what we've gone over so far. We've talked about cardiac anatomy, key terminology like ischemia and infarction, arrhythmia, and stenosis. Those are common things that happen in cardiology. We walked through some of the most common CPT codes for procedures like EKG, stress tests, catheterizations, and pacemaker insertions. We dove into some ICD-10 diagnosis codes for ischemic heart disease, AFib, and heart failure. And we talked about common errors and documentation requirements. But what I really want you to take away is cardiac coding is complex. This is just a brief highlight, and Laureen is going to give you more in the next session that we had. But it's also one of the most rewarding specialties that you can work in. When you code accurately, you're not just helping with reimbursement and compliance, you're also improving the patient's outcome. So good coding supports continuity of care, and that's really all that matters. So build up your confidence, keep learning, use your resources, ask questions when you need to, and remember, precision in cardiac coding really makes a difference. That's so much to take in, but I know that you can do it. So thanks for being here tonight, guys. I hope you enjoyed this cardiac coding, one of my favorite areas. We're going to move on to Laureen's presentation. So I'm going to stop sharing.
All right, very nice, Alicia. Appreciated it. I like this comment. I like your visual explanations of cardiology. This will be useful because she's taking a course in medical billing and coding. Yay. When you get ready to take your certification exam, come back for our blitz to help you review in our time practice exams. Sorry, Alicia, go ahead.
No, I was going to say that is exactly what I was going to tell them, because in our blitz, we not only is the blitz there to help you to bubble and highlight and annotate your manuals, but we also give you those little peeks into how we remember things, and cardiology is a big one. There's a lot of test questions on cardiology.
Very good. Okay, well, for our little break in between. Well, I already shared this with you early. This is our spring sale that's going on, so take advantage. It ends April 5th at midnight. 25% off all of our courses, our full courses, our ancillary courses, and our, I think the blitzes are in there too. So check it out. This is for our announcement about our CDI course. We're continuing to roll out new lectures. They're coming out really good. We're getting good feedback on it. So check that out. CDI is something that really intersects with all of our other courses, whether you're a physician-based coder, an outpatient coder, an inpatient coder. It all ties in. And this course is for all houses, if you will. So it's very comprehensive. We probably should have made it one of our full courses. Oops, what did I do here? We also had a topic maybe a month and a half, 2 months ago on forensic coding that one of our members asked us to present on. And a lot of people were asking, is there a certification for that? And, what's that about? I want to learn more. So we are going to, behind the CDI course, start developing a course on forensic coding. So if you're interested, go to this link here and I'll put it in the chat. And it's just an interest list. You're not, buying anything because it's not ready yet, but you can get on the interest list. And we normally give people that have signed up ahead a good 50% off discount when we get ready to launch it. I'm going to skip that one for tonight. Our YouTube channel, you just put at CCO, or actually, yeah, that's it, after youtube.com. And that's how you can find us. We have videos going way back and lots of new ones being added every day. And we really appreciate it if you can, give it a thumbs up and watch to the end and share. All of that really helps us because we are definitely a word of mouth type of company. And then every Thursday is like we're normally doing something at CCO. So we've got this one is our club one. That's our third Thursday that we're on. Next week, we're going to have the, wait, no, we're doing is it the last Thursday of the month already? Wow. So this is the club. And then the first Thursday, we do the podcast. Those are maybe topics are a little bit lighter, maybe about, career stuff or maybe switching careers, going to like that forensic coding one. The second Thursday is our student and club Zoom call. That's the only one that we don't do a broadcast like we do right now with StreamYard. It's normally a very small, intimate group. So if you are a student or a club member who we consider our premium members, come join us and you can get FaceTime with me and Alicia. I'm going to skip that one. I want to get to a shout out. Boop, boop. Here it is. So this is our congratulations slide. So recently, Julie Frost, congratulations, Julie, passed her CRC exam. And the comments she left for us when she told us she passed was, I love the Blitz. It was a great tool to help me understand more in depth about the different risk adjustment models and how the different audits work. So congratulations to Julie. All right, now I'm going to switch to my deck. All right. So I'm going to be talking about percutaneous coronary intervention, which is PCI, CPT coding for short. And basically, this is one I really loved teaching a long time ago. And it has evolved over time. So that's why I took this one, because Alicia and I were like, okay, these are both very meaty. Which one do you want? So today we're going to be talking about this. And it's one of those areas where a lot can go wrong if you're not like methodical about it. You got to have a system, understand the hierarchy. You got to know like your native vessels. But once you do it, it's really not that bad. Just got to learn like kind of the formula, and then it goes really easy. And we're going to talk about native vessels versus bypass grafts, because that will change your code selection. We need to understand about branches and chronic total occlusions versus like acute MI scenarios, and different device types that they're going to use to take care of plaque and different things. And we'll talk about that hierarchy and help you determine which code you should use first. So we're going to break it all down step by step. And by the time we're all done, you should feel very comfortable reading a cath lab report, identifying the anatomy. You got a little help from Alicia already, and understanding what was done and mapping all that info to the correct CPT code. So this is our first visual graphic here. Again, thanks to our intern and William for putting all these together. And we're going to start with some fundamentals. What is PCI? It's a non-surgical procedure used to treat narrowing of the coronary arteries. So lots of times we hear, oh, you're going to have a heart procedure. And, it does sound scary, but this is, as it goes, not so invasive as other typical surgeries. And what they're trying to focus on is any narrowing of the coronary arteries. And that's normally caused by plaque buildup. And the procedure involves using like a catheter to open up those blood vessels. That might mean like taking a deflated balloon and putting it through and inflating it, or placing a stent, or just removing the plaque with some sort of instrument. And there's even some newer techniques that we'll talk about. So where do we look? Where do these codes live in the CPT book? They're going to be in the surgery section under cardiovascular. And that's important because it tells you that these are procedural codes, not, E&M type codes or diagnostic codes. And they're going to describe what the physician actually did during the procedure. And just as a little side note, cardiology codes, there's a lot of cardiology codes in the medicine section of CPT. So that's why we're kind of emphasizing that these are in the surgery section, the procedures. So the codes themselves are structured around the type of intervention performed. A lot of times when we're teaching in our full class, we talk about what's the main thing you need to understand first. And, this is the main thing. What is the main procedure that was done, the most intense or complex procedure? Was it an angioplasty alone? Was there a stent placement? Did they do an atherectomy? You want to take note of those, highlighted if you're doing a paper report. Or was it a combination? That's important to know too, because that's going to change which code is your main code. And then we need to know how many vessels were treated, and then what kind of vessels they were. Were they a branch, a main vessel, etc.? Because that structure is really going to be the foundation of how we're going to select our codes. Now let's talk about some broader considerations that apply across the board in PCI coding. First, documentation support is absolutely critical. You hear us say that all the time. It's not documented. It wasn't done. Every code you assign has to be backed up by what's in the medical record. So if your documentation from your clinician is like vague, incomplete, or it even contradicts itself, then it's going to be a problem that you're going to have to go back and address. And we cover all that fun stuff in the CDI course, querying the physician and all that good stuff. So PCI is described as minimally invasive, and that means it's catheter-based rather than open heart surgery. The physician is going to access those coronary arteries through a blood vessel, because lots of times we hear heart and we think they're cutting you open right by the heart, but they're not. They can start all the way down in the leg and start that catheter and thread it all up to get it up to the heart to get some imaging, or in this case, they're doing a procedure. They're trying to take care of that narrowing that's going on. And sometimes they can do it in the wrist. The most common is in the groin. And they get that instrument up to the heart, and then understanding that approach, because that could change your code selection. Did they start from the groin area or the wrist? It could change your code selection. So you want to hone in on that when you're reading those reports. And the procedure components are going to include one of three things or a combination: angioplasty, which plasty means repair, angio means vessel, so it's a repair of the vessel. Atherectomy, so ectomy means removal, and ather is plaque. And then stent placement. Sometimes the vessel wall is so weakened that it needs a device to bridge it open, to hold it open. So that's a stent. So those are your building blocks. But here's the thing, they don't always result in separate codes. Sometimes there's combination codes. So we have to pay attention to that, and we're going to go over that. So sometimes, oftentimes, those angioplasties are bundled in if you do an atherectomy or you do a stent. So Each component is going to connect to different intensity levels, how challenging the technique is. So angioplasty of the three is the easiest. Stent is probably the most complicated. So we want to pay attention to that intensity and that hierarchy. And, as usual, these codes change with everything else. Stay on top of it. We do a 2020, we did a 2026 update. We'll do it in 2027. We've been doing these for a long time. So if this is your specialty, if cardiology is your specialty, then you might also want to do a cardiology update webinar as well. And, pay attention to the guidelines and rules around these codes to ensure that you're being compliant in the practice that you're coding for and you're being accurate. So you're going to have to really read like everything, all those parenthetical notes. They give you guidance on the correct code selection. So now we're going to get into, well, we did a lot of the anatomy, but in this case, really focusing on these particular vessels. This is where all of this logic we're going to start building. So we need to know the major coronary arteries and their recognized branches. There are appendices in CPT. I encourage you to go take a look at them that kind of go over this in more of a tabular format. And there's good images in the CPT manual as well. But it's the major ones that we're focused on here. The left main coronary artery is abbreviated LM, and it does not have any recognized branches for our coding purposes for PCIs. It's a main vessel, but it doesn't subdivide into separately reportable branches under the current coding rules. Next, we have the left anterior descending, or the LAD, and that does have diagonal branches, and you'll see those labeled as D1, D2, etc. Those diagonals are recognized branches, which means they can qualify for add-on coding if they're treated separately. Then the left circumflex, or LCX, that has obtuse marginal branches labeled OM1, OM2, and so forth. And the same principle applies. They're recognized branches that would justify an add-on code depending on what was done. Next, we have the right coronary artery, RCA, which can involve posterior descending and posterior lateral branches, recognized branches that matter for add-on coding purposes. Then we have the ramus intermedius, that's abbreviated RI, not Rhode Island. It's a less common vessel, and it does branch off the left main, and it does not on its own have further recognized branches. So why does all of this kind of matter? It's because when you're reading a cath report and you see treatment of LAD and D1, you need to know that that D1 is a branch of the LAD and not a completely separate main vessel. And that distinction is going to change how you code. So it's important to understand this anatomy. And, you can, if you're in the club, this slide would be very helpful. I'm sure you could Google for some images and just type in these abbreviations, LM, LAD, and say image of, and you'll probably find something already out there as well. There's also a caution here about Hicks-Picks modifiers. You might see some modifiers like LD for the left anterior descending, LC, LM, RC, and RI. Only use them if your payer accepts them. Not all payers do. So just, double check that, check your top 3 or 4 payers to see, and then you can make decisions for your practice how to send those out. All right, so now we're going to talk about some of these individual procedures in a little more detail. So first up, the easiest one is the angioplasty. Sometimes it's abbreviated PTCA, percutaneous transluminal. Trans means through the lumina, the opening of the vessel, coronary angioplasty. And it's when a balloon, it's deflated, is threaded up to the area of the plaque, and it gets it right in the middle of the plaque, and then it inflates it, and that like squishes the plaque to the side to open it up. And sometimes, even though that plaque might stay there on the side, it's pushed and flattened, and it makes more room for the blood flow. And sometimes that's enough. Sometimes they'll do it as a preemptive step before putting in a stent. So you need to see all of the procedures that were done in each vessel. What I like to do is as I'm reading it, I will, when I see a main vessel, I'll highlight that in one color, and then I'll note, like circle what the procedure was, and I get that whole report set up. And now I can go to my little tables and, build it out for which codes to pick. So this is often, the balloon angioplasty is often the first step in a PCI procedure, but it's not always separately reportable because it's bundled in if they also do an atherectomy or if they also do a stent. So you have to, I used to, when I teach, I said stents rule. If there's a stent, all the other things are kind of bundled in, but it's changed since then. So I'll explain those nuances in a little bit. All right. But if an angioplasty is performed alone, they do have a code for just reporting that procedure. But if it's done as part of a stent placement or an atherectomy, it's usually bundled. All right, moving on. What's atherectomy? It's plaque removal. And there's different types depending on the device. They have rotational devices, directional devices, they have laser. And this device actually physically removes or breaks up the plaque to create more space in the vessel. And atherectomy trumps or bundles angioplasty. And that means if both are done, you don't code them separately, you just code the atherectomy. Moving on to stent placement, that involves inserting like a kind of like a mesh cage or scaffolding, they call it, to hold the vessel open after it's been dilated. So probably dilated with the balloon angioplasty. The stents do bundle that angioplasty as well. So if the physician inflates a balloon and then places a stent, you're coding the stent, not the balloon work separately. It's bundled in. Then there's fairly new on the scene, a drug-coated balloon, or DCB. It's a newer technique and delivers anti-proliferative drug directly to the vessel wall via the balloon surface. And this came out in 2025 as new codes. And here there's a couple, what are these called? Category 3 codes. So code 0913T is for that drug-coated balloon PCI and includes an IVUS and an OCT. That's the supervision interpretation. And then the 0914T is the add-on for additional lesions treated in the same vessel. So these add-on codes, if you have one lesion, but you're doing multiple procedures, you're going to have one code. But if you have one vessel that has two different lesions far enough away from each other that you can't treat them with one thing, then you get to consider them, code each of them. That's what I'm trying to say. And so this is a cool graphic. It's showing this drug-coated balloon catheter inside the artery. And you can see that that balloon is kind of inflated. I don't think you can see my mouse. And it's just applying that drug to the vessel wall. So hopefully that can help you see how that works. Pretty cool technology. All right, I love this. Is my favorite graph for this whole thing. It really brings this hierarchy into view. And we're going to start actually talking about some of the actual CPT codes. So this is, no pun intended, the heart of the coding structure for this one. And you'll want to notice how they're grouped by intensity, highest, medium, and lowest. At the highest level, we've got the 92943 for chronic total occlusion, CTO, chronic total occlusion. And that's a complete blockage that's been present for a while, and its opening requires significant skill and time. And then there's the 92941 for acute MI revascularization. So there's an emergent situation going on where the patient's having a heart attack and the vessel needs to be opened immediately. So that's definitely a high intensity one. Then medium intensity would be the 92933, which is for stent placement combined with an atherectomy. So that's a combo code. that code includes angioplasty as well. So that's why stents rule. And then code 92924 is just for the atherectomy only. There's no stent, but that does bundle in the angioplasty. And then 92937 is for PCI performed specifically on a bypass graft. That's why I said earlier on, we got to pay attention. Is it a native artery, meaning the one we were born with, or a bypass graft, one that was put in artificially? And that's going to be your code for that one. And then at the lowest intensity level, we have the 92928, which is the most common code. That's for stent placement with or without angioplasty. And then there's 92920, which is angioplasty only, which is the lowest intensity native vessel PCI. So the intensity is really going to dictate which code should be primary, and when you don't try and code another procedure separately. So hopefully this chart will help you and prevent you from undercoding, but it also prevents you from double coding the components that are already bundled. So that's that one. And here's one that's just some little more visual aids about what's actually happening during an angioplasty. And first, you see the plaque build up in the artery, and that's obviously going to cause the artery to narrow, which blocks blood flow. And that's the problem we're trying to fix with PCIs. The next image number 2, they're inserting a small balloon catheter. It's threaded through to get to that point. And then it's very flexible, and it's positioned right at that narrowed area. And then it, after that navigation is done, it gets to the exact lesion, and then comes the balloon inflation, and then stent expansion if that is done as well. And that pushes the plaque outward and expands the artery. And if the stent is being placed, the stent is mounted on the balloon and expands along with it. Pretty cool. And the stent stays to hold the vessel open. And then finally, the balloon is removed and the stent is left in place. So it's deflated to do that removal. So this graphic is pretty cool. It shows all 4 steps in sequence, and it's really good visual aid. But the main thing to remember is angioplasty is oftentimes bundled. All right, and then here's a closer look of that stent placement. Pretty cool. You can see the guide wire. No open heart surgery. They just thread it on up there. And then this one is showing that this tool here to break up the plaque. I'm trying to remember the name of the device. It escapes me. Mechanical, I think they call that one. All right, and then now here's the add-on codes. So this is where if an error is going to happen, it's probably going to be here with the add-on codes. And they're used when additional vessels, not additional procedures, additional vessels or branches are treated beyond the first one. So 92944 is for additional CTO revascularization. That's the complete occlusion. And code 92938 is the add-on for acute MI revascularization in an additional vessel. And then code 92934 is for a stent plus atherectomy in an additional vessel. And 92925 is atherectomy only in additional vessel. 929 is a stent with without angioplasty. And finally, 921 is angioplasty only. So you probably have caught on to the pattern here. These codes are mirroring the base codes that we saw earlier, but the key is that they're an add-on. And that's why we need to know about those branches, etc. All right, so now let's look at some concrete examples here to make it clearer. In example 1, we have an LAD that received a stent plus angioplasty, and then an LC branch that received balloon angioplasty. So the correct coding for these is the 928 for the base code, and 921 is the add-on for the LC branch. And that's one that's marked correct. The common error is to code 2 base codes in the same coronary family, and that would be a Wah, wah, wah. And example 2 shows an RCA chronic total occlusion that's coded as 943 with an LCX stent, which is coded as an add-on 929. And so the CTO is the highest intensity service, so that's why it's the base. And then the LCX stent is an additional vessel. That's why the hierarchy matters, because the highest one gets the base code and the rest are add-on codes. So hopefully it's clicking. And these were the new codes that came out in 2025 for the percutaneous transluminal coronary lithotripsy, 92972. And lithotripsy is using shockwave therapy to break up the calcium in the plaque, making it easier to dilate the vessel and place a stent in there. So it's a fairly new technique. And the documentation requirement here is to specify that this device was used. So if the note just says calcified lesion treated, then that's not enough. You need confirmation that that IVL was actually used. All right, bypass graft coding. So when PCI is performed on a bypass graft, rather than use those native coronary arteries, you're going to use codes like 937. That's used for revascularization through the grafts, whether that's an IMA graft or vein graft. That code includes any PCI technique performed through the graft. And then it also has an add-on code 938 for the additional branches that are done as well. All right, documentation essentials. So first, identify every vessel and branch treated. That's your number one thing. Second, you're going to figure out any devices that were used: balloon, stent, atherectomy, lithotripsy. And the icons here are just kind of visual reminders to document each device explicitly. And then third, you want to note if the case involved an acute MI, because that's going to change your coding selection. Or was it a chronic occlusion or a bypass graft? So look for those buzzwords. And then fourth, use your anatomical modifiers if they're required by the payer. And there's also a note about documenting acute MI, chronic occlusion, or bypass graft status. Those clinical conditions will change which code family you're going to use to tell your story of what was done. So we'll go take a pause here and see what we've covered so far. The main points before we move into some case examples: the hierarchy remains in place. You always code the highest intensity service first. That might be the CTO or an acute MI or a combination procedure. So don't start with the simplest code just because it happened first as you're reading the report. And then there's a new add-on code. Pay attention for that for your lithotripsy, if that was used or documented. And third, verify the documentation and vessel detail. If the op note doesn't clearly state which vessel, which branch, which device, then you can't code it accurately. So you need to query the physician according to CDI principles. And then fourth, review your payer and LCD policies. What do they want? Do they want those modifiers or not? And fifth, expect future revisions to come as more and more new types of technologies come out on how to treat this condition. All right, so let's move into some real world case examples, and I want you to see how all these concepts we've talked about are going to come together. So we'll look at this case one. The patient scenario is a 60-year-old male with unstable angina. Angiography shows 3 areas of disease: LAD with 85% stenosis and calcification, the LCX with 70% stenosis, plus an OM1 branch with 75% stenosis, and an RCA with 45% stenosis, but no intervention planned. This is pretty common. Like when someone starts to get plaque, it doesn't just show up in one place unless they catch it early. You find it in a lot of different vessels. So what was the procedure performed? It was an IVL for the calcified LAD lesion, followed by a stent placement. And then there was stent placement in the LCX and balloon angioplasty only in that OM1 branch. So the documentation requirements are spelled out pretty clearly. You need to specify the IVL device used on the LAD and confirm which vessels were treated. And then you need to confirm that the OM1 is a recognized branch according to your table that we went over. And then you need to document the stent types and sizes. And if you need to note the vessels treated, and you need to note the vessels treated and the complexity level. So the correct CPT coding, the first code, the most complex, is going to be 928 for the stent. And that's with or without angioplasty. That was in the first vessel, which is the LAD. So even though the IVL was used, the primary service was the stent placement. So the 928 is the base. Next, the 972, the add-on for the lithotripsy performed on the LAD. That is what's going to capture the additional work for treating that calcified lesion. Then we have the 929 for the stent placement in the LCX. That's an additional vessel, so that's why it's an add-on code. And then finally, we get a 921 for the angioplasty only in that OM1 branch. And because it's a recognized branch of the LCX and it was a balloon angioplasty only, then the 921 is the appropriate add-on code. So I know we're kind of going through it kind of fast, but these are the kind of slides to come back and, get your CPT manual out, look at the codes, make bubbles around it. Maybe we have, when we, in our back cave, all these pages kind of annotated according to this system, so that if you are getting ready to take a certification exam and a question on one of these is on there, it'll help you kind of refresh yourself on the steps to get to the correct code. This slide is to kind of talk about the rationale a little bit for the previous case, so you can see that logic a little bit behind the code choices. So this graphic is showing the heart with labels for each of the vessels described in the scenario. And this is why your 928, the base code, why that was the suggested code, because the LAD is a major coronary artery and the highest intensity PCI in this particular case. Each case you have to look at, of everything done, which one had the highest intensity work done. So that was the one in the LAD. And that's the standard base code for the native vessel being stented. So why did we use the add-on code for 972 for the IVL? And that's because this new code for 2025 is used in addition to the primary PCI when a calcified lesion are treated with this intravascular lithotripsy. So it's extra work, so it gets an extra code, extra add-on. Why did we assign the 929 code for the LCX? And that's because the LCX is another major artery, and the PCI intervention in that vessel is reported as an additional vessel because we already have one that took the base PCI slot. So you're not going to start over with the new base code. You're going to look for an add-on code, and in this case, it's the 929. Next, we had 921 for the OM1 branch. Why is that? Because it's a recognized branch, so it gets to get credit as a add-on code. And what was done? Balloon-only intervention. So we use the add-on code 921. So hopefully this little labeled graphic will help you understand the scenario that we just went over. Let's see how we're doing on time. 19, okay. A few more slides. I think I'm going to skip case 2 because I don't want to keep you guys too long, but it's on the slides if you want to go over it. I'm going to leave this up for a second, so if you're watching the video on YouTube, you can take a peek there, do a screen grab, and then here's the rationale. These are very meaty topics, so. And we have a case 3. Oh, let me go back real quick so you can peek at that. And then here's the detailed rationale. Really, really good stuff. So, all right. So that's a wrap for this topic. Let me bring Alicia back on with me. Yay. All right. Did we have any questions?
We didn't have any questions per se. We did have one person wanted to know, how long is this going to last?
Oh,
But it wasn't like
yeah.
a bad thing. It's her first time being here, so kudos to her and
Yeah, we
and
normally
everything.
go like an hour to 90 minutes, depending on how meaty the topics are. So
Yeah.
we appreciate you bearing with us. This one does have a CEU already approved, and you can get that in the club. You just go to, if you're a club member, you just go to cco.academy and you'll see it in the replay area, the link. And if you're not, come become a club member and get a CEU for this. You're asked about 10 questions for each hour of content. That's a requirement of the AAPC, and it's a good way to make sure you got out of it what we intended to teach you.
Mm-hmm.
So, yeah, we're loving the graphics.
They're
loving,
so much better to explain. That's why before we decided who was going to do which topic, I couldn't decide. Both of them were so good.
Yeah. So we're very fortunate to have a good team behind us, and we just get to come up here and be the go over these beautiful slides. But yeah, they're called instead of bulleted slides, it's infographic.
Graphics.
And for me, I'm a very visual person, and I find a lot of coders are. So it really helps drive the points home.
Meredith could go 2 hours.
Oh, she loves this stuff.
She loves cardiac. Yeah.
Yeah.
And Sarah thinks we're great. Thank you, Sarah. We appreciate that.
Yeah. Let me just see if we had anything left on our slides that Mary prepared for us. These are all the people that have passed recently.
Shirley enjoyed the PCI and the graphics. That's, it doesn't matter how many times you see the PCI explained, it helps to see it again. You learn something new every time.
Yeah, the anatomy review. This is a slide. If you know of anyone who's taking a course somewhere else and they're not happy, send them our way, because we do have different programs now. We introduced back in the fall of last year our new subscription model, $59 a month, any course, $59 a month. And you can learn a lot in a month. And this way you can supplement. If you've already purchased a full course somewhere else and you're not happy with the lectures and you like our style, then you can come in and just listen to lectures. You don't have to do all our tests and textbook and workbook exercises. But if you want to benefit from our lectures and our support, you get our support. So if you're not getting good support where you are, come join us. You get your own private support room. You get access to me and Alicia and Sylvia and the help desk staff, and we'll help motivate you to keep you on track and going. William will do a little spot check. If we haven't seen any tests come in 2 weeks, he'll say, hey, we haven't seen anything. So we got a team effort, and you're not just a number to us. So if you've been let down by another school, we wish we could have found you first. We hear that all the time. Wish we found you first. I had someone today say, yeah, I found you popped up on YouTube. And I'm like, now, these are people I want to learn from. I really resonate with them. So hopefully through word of mouth, if you can share with your coding friends, we would appreciate it.
Patricia wants to know how to join CCO and get the Batcave.
Yeah, go to cco.us/club. The club is the cheapest way to get access to the Batcave. All of our, we don't sell it separate. If you are a student of any course where you would need the Batcave, you get access to it as well. So it's pretty much all of our courses. You don't really need it for medical terminology and stuff like that, but our core coding courses, you get access to the Batcave. And there's also goodies in the Batcave. There's, let me just remove this. We have exam tips, the art of skipping, how to do process of elimination, POE. And I'm going to be making a new video very soon because we're revamping our exam portal. It's so so cool. You guys are going to love it.
Yeah.
And we're kind of simulating how you do online exams where they're not letting you take a piece of paper in anymore or having an exam booklet to write on, because that was our old way of teaching you. We have to adapt. So how can you do it with that little scratch pad that they give you where you can type notes, and converting our technique to that? You can do it.
Mm-hmm.
It's to me, it's very odd. It's not real world to not have, the ability to even, write on a piece of scratch paper, so, but we'll work with it. So look forward to that coming up soon, but that's all I have. Did you have anything, Alicia, before we say goodbye?
No, just if you're interested in the CDI course, I know somebody had mentioned that, and same place to sign up. And the forensic course, you can sign up for our newsletter, comes with the academy, right? You get an ongoing updated.
Yep. Very good.
And
all right. Well, thank you, everyone.
Okay.
No questions.
It says, can I pay using sale prices for an early renewal? Well, Patricia asked, how much is the cost? Patricia, do you mean how much is the cost of what? The new CDI course? Because that was, I think we had that on the slide.
Well, if you go to that link that I gave earlier with the spring sale, then that will give you all the prices on one nice table. And whichever one you choose, it'll already bake in the coupon code. So thanks to Mary for developing that. Let me find that link here.
There it is. cco.us/spring-sale.
Yep.
It's pretty graphic.
Type that in real quick before I let y'all go.
And the Bat Cave, yeah, that would all be included.
Yes, if you purchase any of those courses on that table or the club, you get access to the Bat Cave.
Right.
With all of our notes on video. Long story, at any rate. All right, everyone. Thank you so much. Really appreciate you all. And we'll see you on an upcoming Thursday, hopefully, or in the academy.
Mark your calendars. We're Thursday CCO night.
All right. Bye, everyone.
Bye.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.